Okay, perfect. First, I want to thank all of the speakers for excellent talks. We got a lot of questions online. Some of them I sort of earmarked, and you can see them on the app, but there are probably 10 times that many that have come through. We're not going to be able to get to every question, but I do want to focus on certain topics during the question and answer period that were sort of touched on repetitively in the people by people who submitted questions. The first one has to do with management of stage 3B, or I suppose revised Mayo stage 4 cardiac patients, the ones who Dara-CyBorD isn't approved for because they were excluded from Andromeda. What are people's preferred regimens regimen for those patients when initiating therapy? Dr. Bianchi, probably we should start with you since this was part of your talk, but I'd be curious to know what the other clinicians do in their own practice regarding this patient subset.
Yep, thank you. That's a great question. Thank you, Dr. Zonder. So I think I alluded to during my talk that I am one of those physicians who would recommend Dara-CyBorD in patients with 3B amyloid, despite the fact that there is no FDA label attached to it. Understanding that I think there are a critical population that is in particular acute need of normalization of free light chain as soon as possible. And therefore, I really feel that adding DARA in this patient population is critical to try to offset the risk of ongoing progression in the setting of ongoing amyloid deposition. Open to my colleagues.
I can answer. Yeah, we are trying to do the same, basically, and otherwise to adapt the regimens for frail patients, including CyBorD or MDEX without DARA. Okay.
Ellie, the question I'll ask is, so in a patient with advanced cardiac involvement in whom you might pick and choose agents, cytogenetics, does it factor into decision making about what one might pick or choose, as their initial therapy? It's a hard question.
I would say this. I mean, I think Dr. Bianchi well presented that you want to have effective therapy that will do it rapidly, that will be the less toxic. And we know that, Velcade might have some cardiac toxicity. It's been kind of touched in the amyloid space, but not too much. We know that, for example, carfilzomib, which is a more potent PI, has a more cardiac toxicity. So there is a potential damage for patients with already established great damage in the heart, given them the Velcade. But on the other end, you want to get the light chains, so it's kind of a balance that you don't know what to do with that. What I would say is that this is probably more applicable to the US because it's more easy to obtain drugs. If a patient does not have a good response to therapy, and I move to the second line, and if, which is sometimes it's a hard choice because you need to have a good second line, and sometimes you don't have, especially patients with severe heart. But half of the patients have translocation 11-14. I go even beyond that. If the patient does not have 11-14 and has enough bone marrow plasma cells, I ask the pathologist to stain for BCL2. Because if the BCL2 is highly expressed, there is a good potential that venetoclax will work on those patients. And I think this medication is quite active. Actually, it's the best active agent as a single agent, I think, in amyloid. I mean, responses that are seen are just amazing. It's not cardiac toxic at all. So if we can move to this agent, not seeing a response that you want to see with the Dara-CyBorD, unfortunately, there are patients that are not responding or not responding well to the Dara-CyBorD. And, we need to get at least a VGPR. So if a patient has a light chain DFLC of 5, this is not a VGPR. I mean, and it's probably after 3-4 cycles, if this is where the patient is stuck, he won't get better. So it's unfortunate, and this is something that's difficult to convince physicians out there that this is a response, it's just not good enough. And if there are alternatives, and I hope that other countries will have those availabilities, then move to the next agent, because you really need to get the light chains down in order to help the patient short run and long run.
Agree. I think continuing to work towards identifying patients beyond the 11-14 subset who might respond to BCL2 targeting is important. There is some work in myeloma from our colleagues at Emory, looking at a B-cell-like gene expression profile or surface marker profile that might predict response to venetoclax-based therapy, which might be applicable to our amyloid patients. I also do want to highlight, just while we're on this topic, there is an abstract on the Aquarius study, which is looking at this exact question of sequencing, starting Cyborg-D and daratumumab simultaneously versus a staggered approach to look at safety. And that same study also has a minority patient cohort built into it specifically, which I think is going to be really relevant. There was an abstract from the Medical College of Wisconsin that is a poster, which was a retrospective analysis of amyloidosis patients based on socioeconomic status and looking at whether or not that had an impact on outcomes. When you think maybe it could, right? That patients in poor socioeconomic categories might have less access to regular, routine, medical screening and observation, less access to testing, and then maybe less resources to manage complications. It turns out they did not see a definite relationship between socioeconomic status itself and outcomes, but they, I think, showed the predictable association between race and socioeconomic status in the United States, and that there was an increased mortality for patients who were Black, even though it wasn't linked to their socioeconomic status. And so that's something that we really, I think, studies like Aquarius are going to be really important to sort of start sorting this out a bit, right? You touched on something that just came up about patients who start with low light chains. We got numerous questions about that. I think 5 different people sort of asked about this. Referrals regarding patients who are suspected to have amyloid based on the presence of congestive heart failure or unexplained neuropathy, and their light chains are minimally elevated, and maybe the ratios aren't even abnormal, technically. They're still in the normal range, but elevated. And this prompts a referral. So I think there's 2 parts to it, right? There's the scenario of getting a patient at that moment, where the question is, does this patient have amyloid? Do we need to do additional testing? That's one. The second one is, if you establish that that patient has AL amyloidosis, how do you follow that patient if the response criteria that we're used to using don't readily apply because their numbers are starting so low? So I don't know who would like to tackle that.
I'd be happy to take this one. So I think there are a couple considerations here. Given the vast predominance of light chain lambda amyloid as compared to kappa, so 3/4 of patients are lambda, any kappa lambda ratio that is less than 1 that suggests that there is excess of lambda light chain in somebody who has compromised renal function, so a GFR that is not normal, should always be taken in consideration as an abnormal ratio. So in this patient, because of the kinetics of kappa versus lambda excretion in the kidney versus reticuloendothelial system, a physiologic ratio should be well above 1, generally above 2. And so patient with kappa lambda ratio of 0.5, I think that was actually your patient, Laura, that's a pathologic until proven otherwise. So that's one thing. The second thing is that we are happy to see, and I'm sure I'll speak on behalf of everybody, rather than not, patients who may have a ratio of 2, 2.5, 2.75, heart failure, nephrotic syndrome, we're happy to see them and then make decision based on a full assessment by hematology, whether or not further workup should be done. The risk of a skin biopsy or a fat aspirate of the skin is exceedingly modest and can be very informative, and so that's certainly something that we considered. As far as how we monitor these patients, I think in patients that have lambda disease, I usually use the criteria of looking for a reversal of the ratio. So even you cannot use the clinical, the approved parameter for monitoring response, a patient with lambda disease who is in a deep remission should flip the ratio from less than 1 to above 1. So that gives you an idea that they're responding well. And then I think we're working towards identifying criteria that just involve the absolute level of the light chain that is involved, or this delta less than 20 that may capture better patients who have this low level of elevation in the light chain. I also give you a bonus answer that you haven't asked me, but I'll ask myself the question and then provide an answer. So I think often of these patients because technically they're not considered high risk, right? The 2012 staging would not consider these patients as high risk because the delta of light chain is not above 180 milligram per liter. However, in my practice specifically, they have posed a challenge in the sense that they're often recalcitrant to respond very rapidly to therapy. And this may have something to do with the effort of protein synthesis and secretion that these cells make on a per cell base, where you may have very little immunoglobulin produced on a per cell base. And some of our therapies, particularly proteasome inhibitors, rely on that secretion process for their activity. So they have a prototypic low-risk disease. However, in my experience, they have a slower response to our therapy as compared to patients that may have very high burden of disease. Just curious to see, maybe Dr. Abelnour, do you have anything else or any other thoughts?
No, I mean, I agree with you, but I think the question is, does a low level mean that you have to stay aggressive with the patient treatment, or is it time to back off? Because, I mean, I think for years, we treated patients with just high-dose chemotherapy, and they're 20 years now still without any problem. So the question is it a balance between sort of production and the ability of the body to eliminate any, amyloid depositions? And I think that's an area that I still don't understand. I would love to see more research on that.
Can I add one more thing?
Please.
Patients come not because they have elevated light chain, they come because they have organ problems. So this is another mode of monitoring the response. So it depends on the presentation, but sometimes patients, we have some criteria for organ responses. Not all organs are, have some biomarker that we can measure, but we can look at the function of the patient. I have a patient with very low DFLC at diagnosis. I cannot assess his response. But a year into his therapy, it took him probably 6 months to get into that stage, is less orthostatic, he's gaining weight, he's doing better, he feels better, he doesn't come with his brother any longer. I know that he's responding to therapy. Now, we have other issues to solve, but we know that this is another, something that you can use in the clinic to assess if he's responding or not, to see what happens to his organ response. Is he getting better or not?
We have a live audience question. Yep.
Hey, I'm Jason Chandler from Memphis. Would you ever use clonoSEQ to do MRD testing in that situation to see if you could get them negative?
Laura, you want to
Yeah,
take the floor?
absolutely. I think it's a good approach to monitor patients on the basis of bone marrow infiltration, also to type and to prove the imbalance between the two different types of plasma cells and to monitor patients according to that. That was done since many years, and in some few cases it's the only way to confirm the clonality of the protein below. I just wanted to add a comment with respect to the case I presented. Actually, MGUS are quite common in the same age range of wild-type TTR amyloidosis. So as hematologists, you will find a significant proportion of patients in which ATTR coexist with the monoclonal gammopathy. It's true that more often these patients do not have unbalanced free light chain ratio, but this is not a criteria to exclude and consider them as wild-type TTR.
And to add to that, the demographics of the most common variant ATTR in the United States, right, the Val-122 isoleucine, right, that's also the much more common in African American patients and in older patients is when it tends to present later clinically, and so there is a huge overlap, you know, epidemiologically, in terms of the patient groups who are, you know, likely to be diagnosed with variant ATTR amyloid in the United States, and also light chain, you know, plasma cell disorders in the United States. So we definitely see a lot of patients, you know, presenting just like the case you presented. I mean, really a common scenario.
And the other point that was not discussed is the coexistence of different type of amyloid deposits, because we have increasing evidence, thanks also to novel approaches for typing of amyloid deposits, that there are patients in which co-deposition can occur either in the same tissue or in different organs. So again, it's extremely important to type to get the final answer.
So that actually is a question that came up in the thread here, which is, so if you have a patient with mass spec proven light chain in their marrow or a fat pad aspirate, and cardiac involvement by amyloid clinically, or by echocardiogram or MRI. But because a lot of patients, if we already know the light chain identity, right, they often will not get a PYP scan, that, you know, in practice. And so the question is, so in an older patient with being treated for light chain amyloid who's having a hematologic response but seems to be having cardiac deterioration, how important is it to go back to the well and actually reevaluate whether the heart is involved by AL?
Yeah, that's a good point. Actually, I think in these patients in which you have a positive PYP and evidence of light chain amyloidosis on a different biopsy, we usually perform also heart biopsy to finally demonstrate that amyloid deposition is related to light chain or TTR or possible coexistence, because actually then you have to interpret treatment response, and you also have to define whether the patient deserves a treatment for cardiac TTR amyloidosis or not. Then there might be restrictions in some countries based on the coexistence of different types of amyloidosis, but I think the most important message is that you have evidence of organ disease and you are able to track response to treatment. So providing typing of the damaged tissue is important in this case.
Yep. We have another audience question.
Hi there. Quick question. What kind of NT-proBNP cutoff do you use to establish whether patients are safe to proceed to transplant? And if they don't meet that goal, how do you eventually de-escalate their therapy if, let's say, all the biomarkers and hematologic response looks adequate?
Yeah, it's a good question that we might have some data. So basically, centers exclude patients on basis of different criteria. One of the criteria that has been used was troponin, but also NT-proBNP at a cutoff of 5,000, which many will prohibit patients to progress to stem cell transplant. And I think that in today's, in time that we have more treatment, that's probably will be justifiable because this is quite elevated NT-proBNP. We are in the works of getting a model to predict transplant-related mortality. We haven't tried to identify a cutoff, so we use what has been available in the literature, and definitely NT-proBNP about the 1800 cutoff is a risk factor for death, but it's only one of the risk factors, so we'll see how it goes with that. If I don't have any other options, and that's the only parameter that is kind of an abnormal, then it's a frank discussion with the patient. We don't have any other options. You might be a good, I don't know if to call it a good, but we can consider you for transplant. There is an increased risk. The risk is around 2% if that's the only marker that is present for transplant-related mortality. And if the patient is willing to take the risk and you're willing to take the risk, then I think this is something that need to be discussed. Obviously, when you exhausted all treatment options, and actually, you know, we have now teclistamab maybe, and anti-BCMA, and we have the venetoclax, so, you know, that decision might be pushed away. For the reduction of the NT-proBNP, it really depends on many factors. Is the patient, for example, on IMiDs, because that will drive the NT-proBNP. Maybe if you pull that off, maybe that will improve the NT-proBNP. A good cardiac care can do that. You know, diet, you know, that the patient don't eat pickle every day, you know. This happens, by the way. So it's kind of, you know, it's a very broad question, but sometimes pulling off treatment might actually help patients rather than, especially if they are in a good response, and give them a treatment break may actually improve their heart function, because treatment is a load on the heart.
Yeah, I just want to echo that and just add, you know, a couple of things. I think NT-proBNP is only one metrics, right, of cardiac function, and one that can be affected, as Dr. Mukhtar said, by so many factors. So we typically put our patients through a cardiopulmonary exercise testing as a functional study to evaluate the cardiac reserve before we undertake the idea of stem cell mobilization and a transplant, and also to decide on full dose melphalan versus dose reduced melphalan in patients that are known to have AL amyloid cardiomyopathy. So that has been very helpful. We have had patients with stage 2 disease and 3A disease that got full dose melphalan actually on the base of really an exceptionally good cardiopulmonary exercise testing. And then I think that the major question, or one of the big questions in the field, is how do we see the role of autologous stem cell transplant currently, right, in the era of a highly effective quadruple therapy up front with many deep response, including MRD negative remission with Dara-CyBorD, and as well as many other options for salvage therapy that appear rather strong, particularly venetoclax and BCMA targeting agent. So a phase 3 randomized study of transplant versus no transplant after Dara-CyBorD induction, sort of molded similar to the determination study in myeloma, is actually being undertaken and in the making, and I think that's going to be crucial data for us to really have an educated discussion with our patients that is supported by modern randomized phase 3 studies.
Okay, we have time for just a couple more questions. I have two specific, I think, questions left, and then after that, you can see the QR code for the post-symposium evaluation, and I would encourage everybody, please fill that out. Also, we're going to, that evaluation repeats the questions, the clinical questions that we asked, and that's how you're going to prove to us that we did a good job up here by shifts in our answers, so please fill that out. First question, I'm going to start with Dr. Abendauer, a practical question about the bleeding and clotting management. So in patients with nephrotic syndrome who are going to be started on IMiD-based therapy, does the presence of nephrotic syndrome, if they've never had let's assume they've never had a thrombotic event, does the nephrotic syndrome affect your thromboprophylaxis strategy in these patients?
So we mentioned that, you know, nephrotic syndrome does increase the risk of thrombosis. Now you add one agent that will increase the risk of thrombosis. So would I use aspirin only like we do in myeloma? I will be hesitant to do that. So I would probably consider ODAC in that setting, you know, an oral anticoagulant.
What do others have a...
So I'm a bit on the aggressive side, I guess. I think we prophylax everybody with DOACs in patients who have nephrotic syndrome, even if they're not exposed to IMiD, because of the thrombotic risk. And we use full doses rather than prophylactic doses of DOACs, generally apixaban, in this patient population if they have an aggravating factor on top of just nephrotic syndrome, whether they're immobile or they are on a therapy that is prothrombotic per se, or obviously if they have had a clot in the past, those are all patients that are going to go on full dose anticoagulation. But we provide anticoagulation in the setting of nephrotic syndrome also only.
I think I follow what Dr. Alberno does, like, the myeloma practice, that if you have one factor, you can probably satisfy yourself with antiplatelet therapy, but if there's more factors, then DOACs should be added. Immobility, if the patient has a neurological condition that is immobile, that is a risk factor, and so that's even before the IMiDs might put the patient on a DOAC.
In my own practice, I have to admit, I don't use DOACs automatically on the basis of nephrotic syndrome, just because review of the literature, it doesn't seem that all nephrotic syndrome is created equal. Like the risk in amyloid patients may not be the same as the risk in somebody like with an IgA nephropathy or some other cause of nephrotic syndrome. But I think that in patients who are going to be treated with IMiDs, when you have that plus plus an IMiD, plus a prothrombotic therapy, I think that does make a lot of sense. And then what I struggle with personally is whether that should be full dose or some sort of low prophylactic dose. And again, my own practice, I'm just going to go on record, I guess, I tend to use a prophylactic dose, not full anticoagulation. So,
I just want to go on a record that I will not give DOAC to just patients because they have nephrotic syndrome. I really have to have other reason for that. Do they have cardiac involvement? Do they have atrial fibrillation? But are they just laying in bed all day long? But I think it's a little bit more aggressive than we probably should, especially if they have some GI involvement and they start bleeding. I think that will create more problems.
All right, and then the last topic that I wanted to sort of bring up in questions, there was a abstract that's been getting some attention from Dr. I want to make sure I get this right, from Dr. Zhang, abstract 536, an assay looking at homodimeric light chain constant domain fragments as a means of detecting a blood assay for detecting lambda light chain amyloid. Which looks very sensitive and specific. It's impressive data. And I think about that like in the context of other serum-based tests like glycosylated light chains, things that other things that have been looked at as maybe screening blood tests that we might bring to bear for patients with suspected amyloid, especially I'm thinking about like an MGUS patient who has neuropathy, where you do your workup, you've done your bone marrow, you've done your fat pad, it's negative, and you know that 10% of patients with amyloidosis haven't been picked up yet, right? And so like how can we use these kinds of blood tests, or if we can use these kinds of blood tests to help us? Can anyone, I'm welcome anyone's opinion, does anyone envision them being just a diagnostic test that we do and use? Or are they the kinds of things that might factor eventually into some sort of machine-based learning algorithm where it's like if you have certain symptoms and this test is positive, it helps improve the accuracy, the positive predictive value of these kind of machine learning algorithms? I'm going to ask people what they think. It's a hard one, but this abstract was really interesting, I thought, and so.
So I think we need a screening test for light chain amyloidosis. The problem with this disease is the delayed diagnosis, not picking up too many patients that then turn out not to have it. So I think if you want to increase a bit, or restrict the pool of patients that we should screen with this kind of assay, if they're validated, will be patients who have an abnormal light chain ratio, for instance. So you sort of narrow it down to that patient category, missing hopefully very little patients that don't show up with an abnormal light chain level or kappa lambda ratio, or obviously the presence of red flag symptoms. last 2 years ago, a year and a half ago at ISA, there was data presented out of Pavia, right, about implementing NT-proBNP and albuminuria screening on all patients with MCAS and smoldering, you know, picking up about 1% of patients with amyloid that you wouldn't have picked up had you not do that. So I really think efforts that move toward early diagnostic and screening procedures are critical in this disease. So I'm very excited to hear more about that.
Yes, a more general comment is that we need also for transthyretin amyloidosis the identification of misfolded species that can predict, for example, conversion for presymptomatic carriers to affected patients, or can help us monitoring response to treatment, because in ATTR amyloidosis we are far behind light chain amyloidosis in the sense that we don't still have a marker of response to this treatment, because also the mechanism of action is completely different. You can either suppress, and in this respect we have a roughly threshold for considering the patient's responder, but stabilizers are not to increase the concentration of circulating TTR. So we still don't have TTR as a biomarker for response. In that case, it would be particularly interesting to measure the ratio between misfolding TTR to stable TTR in order to understand what's going on. So all these tests, I think, are quite welcome.
Right?
If I may say, sorry. Yes, please.
Nothing.
I'm involved in this work, so I'm a little bit biased, but I think that we have a good screening for amyloidosis. This assay, if it will be proven effective, it's really for confirmation of diagnosis. We really need to work across all monoclonal gammopathies to see if it's really, has a good negative and positive predictive value, so we won't make mistakes, because we are making mistakes with amyloid all the time. We are developing clinical guidelines, and we kind of falling always in the traps of amyloidosis. So I think we have good screening, but obviously it can improve, even if it won't be a confirmatory test. But it will be amazing if we have an assay that we can do it from the blood that will tell us if the patient has amyloidosis or not. So
I agree, a holy grail type of test, right? I mean, that's I think what we would all really like to see.
And it's only lambda, so that's a caveat.
It's limited, right? Limited to lambda so far. Okay, we are over time. Thank again all of our speakers. Fabulous discussion today, and thank you to our sponsors and also to the audience. We had incredible attendance today, and I appreciate how many of you stuck it out the entire time. Thanks so much.